I want you to imagine a scenario. You're sitting in a clinic room, you've tried the steroids, you've tried the biologics, and then the doctor looks at you and says, I think it's time to call the surgeon. For most patients, that moment feels like the end of the world, isn't it? It feels like failure. You think, my body has failed, the medicines have failed, and now I'm going to be cut open. But today, I want to reframe that for you. Did you know that 1 in 5 patients suffering with Crohn's disease will need major surgery within the first 5 years of their diagnosis? It's not rare, and more importantly, it's not a failure. For many of my patients, surgery is the moment they get their life back. It's the moment the pain stops. It's the moment they leave the house without panicking about where the toilet is. Hi, I'm Dr. Dhingra, a consultant gastroenterologist working in the NHS. This is going to be a deep dive, and I'm going to explain exactly what happens in the operating theatres, the tube you'll wake up with, the truth about stoma bags, and how to recover safely. So grab a tea because we have a lot to cover. First, let's talk about why we do this. There is a misconception that we only operate when you are at death's door. That's definitely not true. Sometimes surgery is actually the first or the best option. There are 3 main reasons I send the patient to a surgeon. The number one is the stricture. So Crohn's disease causes inflammation. When that heals, it forms scar tissue. If you get enough scar tissue in the bowel, it tightens like a belt. We call this a stricture. Unlikely a medication will turn that scar tissue back into normal bowel. If food can't get through, you need blockage. You get blockages, you get pain and vomiting. And surgery is the only mechanical fix for this mechanical problem. Number 2 is the abscess or a fistula. Sometimes the inflammation burrows right through the bowel wall, creating a tunnel, what we call a fistula, or sometimes it creates a pocket of pus, what we call an abscess. These can make you incredibly sick with infection. And number 3 is the cancer risk. This is the scary one, but we have to be honest and admit that if you have had Crohn's in your large bowel for more than 10 years, your risk of bowel cancer is higher compared to the general population. Sometimes removing that part of the bowel is the safest way to prevent cancer from developing. Okay, so the decision is made. What happens in the weeks before the surgery? This is the part patients often ignore, but I would say that it is very critical. We call this rehabilitation, getting your body fit for surgery. So first, let's talk about the medicines. We might need to stop your medication. If you're on steroids, we need to taper them down because they can increase the risk of infection. If you're on blood thinners, those need to stop as well. Interestingly, for some biologics, like infliximab, we might try to time the surgery so it's not right after a dose to help the wound healing. Second, the smoking. And if you smoke, you need to stop now. Smoking reduces blood flow to your wounds. It makes the risk of the bowel joint leaking much higher, and long-term smokers are more likely to have the Crohn's come back even after surgery compared to patients who don't smoke. So please stop smoking. Third is the nutrition. You might be underweight. We might put you on a special liquid diet or maybe some iron supplements if you're low in iron to help your body build up leading up to the surgery, so your body has the building blocks to heal the wounds and handle the stress of the surgery. Now let's go into the operating theatre. What exactly are they going to do to you? So most of the time the surgeons try to do a keyhole surgery, what we call a laparoscopy. Instead of a big zip down your tummy, the surgeons make four tiny cuts about a centimeter long. They inflate your tummy with gas to create space and use a camera to work with. Why do we love this? Because it causes less pain, smaller scars, and you get out of the hospital faster. There are three main procedures you might hear about. One is the resection. This is the most common one. The surgeon finds the bad bit of the bowel, cuts it out, and joins the two healthy ends back together. This is called an anastomosis. Second is the strictureplasty. This is clever. If you have a stricture or a narrowing, but we don't want to remove the bowel, the surgeon cuts the narrowed area lengthways and sews it up crossways. So what it does is, it widens the pipe without losing any gut length. We call this bowel preserving surgery. The third thing surgeons might do is a colectomy. This is where we remove part or all of your large bowel or the colon. This is a bigger surgery. I have to talk about the stoma. This is the number one fear for 99% of my patients. A stoma is where the bowel is brought out onto the surface of your tummy and your poo goes into a bag. First, please know, not every surgery ends in a stoma. We can join the bowel back together straight away. But sometimes we need to give the bowel a rest, a time to heal. This might mean a temporary stoma for a few months, and sometimes we need a permanent stoma. I know the idea of a bag is terrifying. You worry about body image, you worry about the smell, you worry about relationships. But let me tell you what my patients tell me after they get one. There was a study where 7 out of 10 people said their quality of life improved after stoma surgery. Why? Because before the stoma, they were going to the toilet like 20 times a day. They were in pain. They were exhausted. With the stoma, they sleep through the night. They go out of the house fearless. They travel. The bag didn't trap them. It set them free. Right. The surgery is done. You're in the recovery room. You wake up. What does it feel like? I want to manage your expectations here. You are going to wake up with some tubes attached to you. Don't panic. This is normal. You might have an IV drip running in your arm, in your veins for fluid and some painkillers. You might have a catheter, which is a tube in your bladder to drain your urine so you don't have to get out of the bed. You might have a drain in as well. You might have a tube coming out of your tummy to drain fluid from the wound. You might find yourself in an oxygen mask just to help you breathe as the anesthesia wears off. And pain, yes, your tummy will be sore. It will feel like you have done 1,000 sit-ups. But we have good painkillers. You might have a button you press to give yourself some pain relief. This is what we call patient controlled analgesia or PCA, or you might have an epidural in your back. Depending on the situation, we'll try to get you out of the bed as quickly as possible, often the next day. Why? Because moving stops blood clots and gets your gut working again. So now you're home, the scar is healing. What now? First, let's talk about diet. For the first few weeks, you might need a low fiber diet. Your bowel is swollen and needs an easy food. As it heals, you can go back to normal slowly. Driving? You cannot drive until you can perform an emergency stop without pain. This usually takes a few months. It's best to check with your IBD team or surgeon. Let's talk about fertility. If you're a woman planning to have children, please tell us before the surgery. Surgery in the pelvis can cause scar tissue that affects fertility. But keyhole surgery reduces this risk significantly, and most women can still have healthy babies or healthy pregnancies, but you might need a cesarean section. Next question is what I ask most in my clinic is, will the Crohn's come back? This is the hard truth. Surgery is not a cure. Crohn's can come back, often near the site of the joining of the bowels, but surgery resets the clock. It can give you years, sometimes decades of remission. And if you stay on your meds, you don't smoke, we can keep you well for a very long time. So, if your doctor mentions surgery, take a breath. It is a big deal, but it's also a well-trodden path. Thousands of people have walked this road before you, and most of them wish they hadn't waited so long for a surgery. It's not about giving up, it's about getting well. If you have questions about stomas, or if you have questions about recovery, put them in the comments below. I read them all and try to answer them. Please like the video and subscribe to my channel for more such related videos about your gut health, Crohn's disease and ulcerative colitis. I'm Dr. Dhingra. Take care of your gut and see you next time. Thank you.